Greetings, my name is Cinnamon Dixon. I am a pediatric emergency medicine physician and medical officer in the Pediatric Trauma and Critical Illness Branch, or PTCIB, at the Eunice Kennedy Shriver National Institute of Child Health and Human Development, or NICHD. The PTCIB was established in 2012 with a mission of supporting research and training activities aimed at preventing, treating, and reducing all forms of childhood traumatic injury and critical illness across the care continuum. The PTCIB's priorities center on the prevention and treatment of traumatic injuries, collaborative multidisciplinary research across the continuum, and psychosocial issues related to the care of critically ill and injured children and their families. NICHD's partnership with HRSA on Emergency Medical Services for Children, or EMS-C, extends as far back as 2 decades, at which time a multi-agency program announcement was released focusing on improved quality and quantity of EMS-C research. Since that time, our partnership and NICHD's work in this field has continued to grow. NICHD currently supports a robust portfolio of EMS-C related activities ranging from cooperative agreements to research grants and training awards. The NICHD and NIH have multiple current funding opportunity announcements available for investigators and trainees to promote research in the emergency setting, as well as research on trauma and injury, violence and firearms, medical simulation, health services related to minority health and health disparities, and disasters. Additionally, NICHD has a current Notice of Special Interest published soliciting research on EMS-C. We also welcome investigator-initiated applications in this field. Here at PTCIB, we are currently most excited about supporting work that will address one of the biggest gaps in the field, the equity and quality of care for children within the emergency medical system. It is no news to this audience that disparities in access to and the provision of optimal emergency care for children exists within the United States and globally. And the PTCIB is committed to helping address these care gaps through our investments in research and training. Furthermore, we believe that some of the best solutions to these gaps incorporate research and training, advances across the continuum of care, and the full translational spectrum of science, meaning that EMS-C science takes an approach not only from bench to bedside, but from bedside to curbside. Hence, in addition to bench and clinical practice advances, our support of EMS-C research focuses on expanding the number and availability of evidence-based diagnostics and interventions via dissemination and implementation science. It encourages research that operationalizes the use of electronic modalities and other advances in care delivery to increase reach of best practices. And it supports multidisciplinary science, which partners with local and regional communities in participatory research and other endeavors to address systemic inequities in risk and care. As a leader in this area of science for our branch at the NICHD, my vision for the future of EMS-C in the United States and globally is that all children will have the same access and availability to high quality care in an emergency situation, regardless of their age, race, gender, economic status, geographic location, or underlying disability. To reach this goal, optimal emergency care services for all populations, and especially children, must be embedded into the fabric of the pre-hospital and medical home setting, the emergency departments and hospitals, and beyond. I look forward to continued collaborations with HRSA and other relevant agencies to promote a future of EMS-C in which pre-hospital systems and providers are trained and ready to deal with pediatric emergencies. Medical home providers are skilled and regularly practicing for emergencies in the clinic. Emergency medical providers provide safe and evidence-based practices for the many conditions they encounter every day. Emergency departments have access to pediatric specialists, whether in person or remotely, to manage severely ill or injured children. And that EMS-C programs partner with schools, communities, medical home systems, and mental health organizations to increase capability and capacity of these groups to respond to pediatric emergencies within their day-to-day scope, and also to build systems and infrastructure which can be leveraged in the context of a public health emergency. I would encourage any EMS-C researcher or grantee to keep checking the NICHD website for updates on current and future funding opportunities, as well as it can be helpful to review the NIH Reporter to get a sense of our current investments and to discern where there may be opportunities for collaboration. And finally, don't hesitate to reach out to myself or any of my colleagues to discuss your area of science and learn more about how we can potentially support you. And my final message to all of the current and future EMS-C grantees working to improve emergency care for children is thank you. Being a provider in the field of EMS-C is both a daily challenge and a reflective privilege. Caring for a child and their family at the most vulnerable moment of their life is a great honor. However, reaching beyond the bedside to improve care and decrease inequities for all children who may enter the emergency medical system now and into the future, that is the most noble of endeavors. And we at PTCIB and the NICHD are grateful for all that you do. Thanks. Greetings, my name is Cinnamon Dixon. I am a pediatric.
Hi everyone, welcome to NEDARC's data discussion on the EMS for Children survey and the NPRP assessment. We're excited to bring you this session today. It's going to be broken up into two parts. The first part will be on the EMS for Children survey, and then will be followed by a session on the NPRP assessment, which ends today, excitingly. So for the first part of the presentation, we're going to have Braden Green, which is our business data analyst, and Patty Schmuhl, which is the NEDARC data manager. Then for the second part on the NPRP assessment, we're going to have Dr. Hilary Hewes, which will not be able to join us today, but with the recorded information. And then we'll have Jane Ostler, our NEDARC business data analyst, and Michael Ely, our NEDARC director. We'll be monitoring any questions that come up in the chat. If we're able to answer them, we'll go ahead and clarify those questions, but we will try to leave about 10 to 15 minutes towards the end so that we can answer questions that require a little more thoughtfulness. So let's get started.
Hello, and thank you all for joining us today. I'm Braden Green from the NEDARC team, and we are going to discuss a few of our recent projects as part of the Emergency Medical Services for Children program. None of those from NEDARC who are presenting today have any financial disclosures to report. First off, what is NEDARC? NEDARC stands for the National Emergency Medical Services for Children Data Analysis Resource Center. NEDARC's role within the EMS-C program is to help EMS-C program managers and EMS offices with all things data related. We also provide technical assistance and customized software to EMS-C grantees, EMS agencies, hospital EDs, and state EMS offices in the areas of performance measures, data collection, data analysis, data communication, publishing in peer-reviewed journals, and quality improvement. HRSA funds the EMS-C Data Coordinating Center, which is comprised of both NEDARC and PCARN. The goal of the Data Coordinating Center is to collect, analyze, and disseminate data related to EMS-C programs and projects. To help accomplish the overall EMS-C goal of providing the highest care to all pediatric patients, the program created 9 performance measures, which are a set of benchmarks in pediatric emergency care. These measures can be split up into 3 types: pre-hospital, hospital, and permanence performance measures. Those with an icon here on this slide are the performance measures for which NEDARC has been tasked with collecting data. We'll explain those performance measures in more detail shortly. To help describe and define each EMS-C performance measure and to establish benchmarks to measure progress along the way, NEDARC developed the EMS for Children Performance Measures Implementation Manual in 2017. This manual is always available at nedarc.org under the Performance Measures tab, and the link is also available on the 2021 Annual Grantee Meeting webpage for this session. In regard to the performance measures, our job is to work with EMS-C program managers to collect data on 2 of the pre-hospital performance measures and 2 of the hospital-based performance measures, analyze and help the program to visualize that data, and then use the information to push forward quality improvement initiatives to raise the bar for pediatric care across the United States. Next, we're going to go over the 4 performance measures for which NEDARC manages the data collection, live reporting, data analysis, and dissemination. EMS-C02 is concerned with the percentage of EMS agencies in the state or territory that have a designated individual who coordinates pediatric emergency care. The program's goal is that by 2026, 90% of agencies will meet the requirements for this performance measure. The person responsible for coordinating this care is called a Pediatric Emergency Care Coordinator, or PEC, and you may also have heard of a PEC being called a Pediatric Emergency Care Champion. A PEC is responsible for coordinating the various aspects of emergency care of pediatric patients within an EMS agency. Among other tasks, this includes ensuring an ambulance carries proper pediatric equipment, that the agency has specific pediatric protocols, and that EMS providers get pediatric-specific training. EMS-C03 is concerned with the percentage of EMS agencies in the state or territory that have a process that requires EMS providers to physically demonstrate the correct use of pediatric-specific equipment. That is to say that the agency has a process for conducting skill checking on pediatric-specific equipment. Similar to EMS-C02, the program's goal is that by 2026, 90% of agencies will meet this performance measure. Moving on to the hospital ED-based measures, EMS-C06 is a hospital ED-focused performance measure that is concerned with the percentage of hospitals with an emergency department that have written interfacility transfer guidelines to cover pediatric patients. Further, the interfacility transfer guideline must include the bulleted processes seen here. If you'd like to go through these in detail, I recommend downloading the EMS for Children Performance Measures manual mentioned previously. The program's goal for EMS-C06 is that 90% of hospitals with an ED will meet this measure by this year, 2021. EMS-C07 is also focused on hospital emergency departments, and it measures the percentage of hospitals with an ED that have written interfacility transfer agreements that cover pediatric patients. So to clarify, EMS-C06 measures the hospitals with interfacility transfer guidelines, and EMS-C07 measures the hospitals with interfacility transfer agreements. And as with EMS-C06, the program goal for EMS-C07 is that 90% of hospitals will meet this measure by this year, 2021. In order to collect data on these 4 performance measures, NEDARC hosts and manages data collection periods. We work hand in hand with the EMS-C program managers to accomplish this, and there's no way we could collect all this data without their help. 2021 has been a unique and very busy year because in addition to the annual EMS for Children survey, we also have managed and hosted the 2021 National Pediatric Readiness Project assessment. The first survey completed this year was the EMS for Children survey. This survey is held annually from January to March and is used to collect the pre-hospital performance measures, that is EMS-C02 and 03. All EMS for Children survey communications are distributed to EMS agencies via email, but the EMS-C program manager is able to make a choice whether they want NEDARC to send those out to the EMS agencies in their state or whether they want to handle that themselves. And regardless of distribution method, NEDARC hosts, analyzes, creates visualizations for, and disseminates all the collected data. The second data collection NEDARC is hosting and managing this year is the National Pediatric Readiness Project Assessment. This assessment is directed towards hospital emergency departments and is much longer and collects many more data points than the EMS for Children survey. And my colleagues are going to speak more about the NPRP in a couple of minutes, but I just wanted to mention that this year, EMS-C performance measures 06 and 07, those are the two hospital-based measures, are being collected as part of the NPRP. And this assessment opened on May 1st, and it will close at the end of the day today, August 31st. For the NPRP, all survey invitations and reminders were distributed centrally by NEDARC via postal mail directly to hospital EDs. And program managers have been invaluable in following up with hospitals via email and phone. So now that we've had a quick summary of who NEDARC is and some of what we do within the EMS-C program, we're going to hear from our NEDARC data manager, Patty Schmuhl. She is going to go over some of the data we collected from the EMS for Children survey this year. And after that, Jane Ostler, Mike Ely, and Dr. Hilary Hewes are going to present on the NPRP.
Thank you, Braden. I'm Patty Schmuhl with the NEDARC team and happy to be with you today. Let's jump into the results of the EMS for Children survey. First and foremost, we'd like to say thank you to all of you for assisting and asking your EMS agencies to participate in the 2021 EMS for Children survey. As Braden mentioned, we couldn't have done this without you. Just a quick overview of what we'll discuss: the survey launch and close, some challenges in the last year. We'll review the results of EMS-C02 and the results of EMS-C03. We'll look at some of the dissemination of data that's been done, and finally, some of the next steps for this survey. First of all, we had 58 states and territories participate in the assessment, which amounted to 15,768 EMS agencies who respond to 911. An EMS agency must respond to a 911 call or dispatch to be included in the survey. The survey opened in January 2021 and ran until about mid-March 2021, as the Pediatric Readiness assessment was starting to ramp up. We knew it would be a difficult year for high response rate, but we were actually pleasantly surprised as our initial estimates of 20 to 30% ended up to be a 45% response rate. 7,025 EMS agencies that respond to 911 participated in the survey. We wanted to show you a histogram with a few statistics so you could see the wide range of agencies that exist across all states and territories. The numbers run from one agency, usually a territory, to over 1,500 agencies in one state. You can see that most states fall within the 100 to 400 EMS agency group, which is about 28 states. And just for interest's sake, we can also look at the response rate in each group and see that from left to right, the response rate goes from high to low. So long story short, the number of agencies per state and territory varies largely, and achieving a high response rate for states with many agencies can be more difficult. Let's mention a few of the challenges from the 2021 survey, which mainly focuses around the pandemic. We do absolutely want to let you know we appreciate and applaud the efforts of all the EMS providers and many EMS-C managers who gave up their time to help us stay safe and to save lives. First of all, the largest challenge was the drop in the response rate from 2020 and 2017-18. The goal of the EMS-C program has and will always continue to be 80%. However, due to the pandemic and the added stress on resources for EMS agencies and EMS-C managers, HRSA decided to ask NEDARC to send out 2 contacts to EMS agencies, an invitation and a reminder, compared to 5 the year before. Managers were also given discretion to contact agencies based on their available resources due to the pandemic. We all know we had an overtaxed medical system with busy providers, and in some agencies, the call volume dropped and jobs were lost. Many of our EMS-C managers were diverted from their EMS-C activities to COVID duties. Finally, the biggest challenge is the agencies that have participated each previous survey year dropped by about 2,000 EMS agencies. This significantly affects looking at overall trends, especially the one-to-one trend charts, where we look at specific agency growth over time. Some states went from having 100 agencies or more that participated in all survey years to about 6. So this basically makes the one-to-one comparison unusable. This could be, unfortunately, an issue going forward. However, even with this drop, we still have 3,393 agencies that have participated in all survey years, which is fantastic. The contact system for reaching EMS agencies consisted of 2 options, as Braden mentioned. One was to have NEDARC send out all communication via email, which was 2 contacts in 2021 due to the pandemic. This group ended up with a 39% response rate and surveyed almost 10,000 EMS agencies. Option 2 was that all communication via email or phone was completed by the managers on their own. NEDARC did supply contact templates. However, we knew and acknowledged the contact may be limited to pandemic. This group finished with a response rate of 54% and surveyed 5,786 EMS agencies. We'd just like to point out the significance of contacts, even if it's just by email, as seen here for the option 1 states and territories. There are 2 matching spikes of over 300 respondents in one day, which is a lot. And that happened just after those contacts were made. You can see from the option 2 group that there is a consistent contact over the entire survey period. Because of this consistency across the entire period, most agencies likely received more than 2 contacts. We also believe that many managers have some recognition in their EMS system. We've always known that managers make a difference. So let's jump into the results, which you've all been waiting for. After cleaning the data and excluding any agencies that are not eligible for the performance measure calculation criteria, such as IHS, tribal, and military agencies, we were left with 6,910 EMS agencies as our denominator for the analysis. Let's look at EMS-C 02 first. As Braden explained earlier, this is the presence of a Pediatric Emergency Care Coordinator, or PEC. So nationally, 35.7 of the agencies reported having a PEC, and of those agencies, 81% have a PEC that only oversees their own agency, and we do have over 22% of agencies that plan to add or are interested in having a PEC. If we look at the duties of the PEC reported by the 36% of EMS agencies, we can see we have high percentages in most of the key important areas, such as continuing education, protocol development, proper medication and equipment. We start to fall off at family-centered care, coordination with ED PECs, which is becoming very important, and research efforts. States were able to report other activities and provide a description of what those were, most being car seat installation and inspection, training, and other preventative safety issues. Let's quickly take a look at the trends over time for EMS-C 02. This first graph, which scale has been adjusted so you can see the percentages in a slide format, shows an overall upward trend in EMS agencies, reporting that they do indeed have a PEC. Due to the low response rate in 2021, our statisticians are able to adjust for the difference in respondents for each survey year and run a statistical test to see if this trend is significant. And indeed it was. So as a program with EMS-C 02, we are on an upward trend for this measure, which is awesome. Furthermore, if we look at the 3,393 agencies that participated in all 3 years, the one-to-one group that we mentioned earlier, and using the same statistical analysis, this trend is also significant with a stronger and higher upward trend for those that participate every year. Let's take a look at the EMS-C 03 results now, or the skill checking on the pediatric specific equipment. There are three main domains for skill checking on equipment: demonstration at a skill station, a simulated event, and a field encounter observation. Respondents receive points based on how often or frequently they practice these skills, with 2 or more times a year being the highest score and less than once every 2 years the lowest. In the matrix shown here, any combination from these three domains that adds up to 6 points or more is counted as meeting the EMS-C O2 metric. If we first of all look at the agencies that reported skill checking on pediatric specific equipment, we can see that demonstration of skills at a skill station and simulation are high at just over 70%, and field observation is low at 29%. But keep in mind that EMS providers see a very low volume of pediatric patients, so field observation is very difficult. Nationally, the result for EMS-C 03 is 24.6% in 2021. Our statisticians developed 4 groups of skill checking on a pediatric specific equipment to make this measure a little more understandable. It runs from no training or very little all the way to extensive training. The boxes in red indicate agencies that reported meeting the 6-point metric. As a nation, the median score is a 3, which puts us in the limited training group, so we've got some work to do. Let's take a look at this data in the matrix format you saw earlier. The color coding of this heat map goes from orange, lowest percentages, to blue, highest percentage. Most agencies that do some type of skill checking on pediatric specific equipment fall in the at least once per year column for skill checking and simulated event. If we look at those that reported no training at all, we can see about 1/3 report no skill checking at a station or simulated event, and over 70% have no skill checking in the field. If we filter this data by those agencies that reported having a PEC, these numbers definitely change for the better. The percentage for those that demonstrate at a skill station alone in the 2 or more times a year column went from 14% to 21%, which is fantastic. In fact, the first 2 columns increase in all percentages, which is great news, and the none column decreases by about 10 or more percent in each skill checking domain. So this underscores the importance of having a PEC. Let's take a peek at our overall 3-year trend for EMS-C 03. Again, the scale in this graph has been adjusted so you can see the numbers easily. Keep in mind, if the scale was 0 to 100%, this would almost look like a straight line. We can see a peak in 2020 and a small drop of 1% in 2021, about 475 agencies. According to statistical analysis, which takes into account all the differences in each year, this graph is also significant, meaning there is a significant difference of reporting in all years. When we look at those 3,393 agencies that participated in all 3 years of the survey, our one-to-oneers, we see the same type of graph with a small 0.7% drop in 2021. However, this graph is not statistically significant. So really over these 3 years, looking at the one-to-one agencies, not much has changed for them for EMS-C 03. We have made an effort to disseminate as much of the data as possible to our EMS-C grantees. Not as much as we'd like, but we are a little thrown off schedule with the large and exciting PEDS Ready assessment, which Braden mentioned. Our Tableau dashboards and visualizations total about 15 individual dashboards with both state level and national summary data. We completed a national summary of all the data that is targeted for all possible respondent EMS agencies, the 15,700 plus we mentioned at the beginning. It was recently emailed to all of those agencies to keep them engaged about what is going on and to keep interest in the survey. We're in the process of finalizing some fact sheets that can be shared with the public and/or congressional representatives. We've also spent a lot of time creating some briefs and statistical reports as requested by HRSA for reporting the results of the survey up the chain. We expect to provide you with more resources as we are able. Finally, as far as next steps, we continually ask EMS-C grantees to explore their state and territory summary data on the Tableau visualizations to look for areas of improvement and to share these results with state and territory stakeholders. As I stated earlier, we are working as hard as we can to get you additional reports on an EMS agency level so targeted efforts can occur. These will include QI-specific dashboards, which should be up soon in Tableau. Dissemination of results will continue as we also work on providing grantees with regional summary data and other means of sharing the data, such as fact sheets. Finally, the last step, which is already coming up soon, will be to prepare again to survey in January 2022. So we just need to breathe. We know this has been a very busy and stressful couple of years with the pandemic and many surveys happening. We want you to know that you are very, very appreciated for all the work you put into EMS-C. We send you a huge hug and thank you from all of us at NEDARC.
We appreciate the opportunity to discuss updates about the National Pediatric Readiness Project Assessment. We've got Dr. Hilary Hewes with us today, Michael Ely, who is our NEDARC director, and I'm a business data analyst. My name is Jane Ostler. The NPRP assessment has been an adventure, to say the least. Like many adjustments that were made during 2020, the launch of the pilot was postponed due to COVID-19. We asked Stacy Casada and Kathleen Adelgaze of Colorado and Amanda Perry and Heike Griffin of Louisiana if they were still willing to participate as pilot states from September through November of 2020. After careful consideration, they courageously agreed and put forward a phenomenal effort. We want to thank them publicly here and congratulate them and their hospitals for yielding an impressive 93.9% combined response rate. This was all done in the face of a public health crisis, hurricane season, wildfires, and other disasters going on in their state, so we cannot thank them enough for their efforts during those challenging times. The pilot was the first time that NEDARC was able to monitor response in real time to test what monitoring would look like during the forthcoming national assessment. The pilot also helped to inform the NPRP marketing package for the national launch and future reports and Tableau dashboards. Let's jump ahead in our timeline to May 2021 and the successful launch of the national assessment, which had also been delayed due to COVID-19. In addition to the pilot, more than 5,000 postal invitations were sent to ED nurse managers at hospitals across the United States and territories. Over the course of the data collection period, we sent a total of 6 mailings, which included 4 letters and 2 postcards, in addition to countless marketing efforts from our partners nationwide. As you may have guessed by looking at the close date of August 31st, we're still in the process of finalizing data collection. So at this time, we do not have a national aggregate score or analysis to share, but we will share it with our stakeholders as soon as it is ready for broader dissemination. We want to express a hearty thanks to our EMS-C program managers for their incredible efforts and acknowledge the difficulty of participating in consecutive data collection projects. Our appreciation also goes out to all of our ED nurse managers who responded to the call to take the assessment and our national partners, HRSA, EIIC, ENA, ACEP, AAP, ACSCOT, the NPRP Steering Committee, NASEMSO, countless people working behind the scenes, and especially our NPRP project co-directors, Dr. Marianne Gaucher-Hill and Dr. Kate Remick, for their tireless efforts and inspiring leadership. It definitely takes a village to pull off a project like this, so thank you so much, everyone. Now let's go ahead and turn it over to Mike.
Great, thanks, Jane. And let me also say to managers and others, thank you all so much for your efforts in this process. This is a screenshot of our national response rate map as of August 6th. And at that point, you had 3,134 completed assessments for an over 60% response rate, which is really impressive when you think about it. And again, that simply could not have been achieved without all of your efforts. As of August 13th, when this session was recorded, we had received more than 50 additional surveys from hospitals, and we do anticipate receiving several more before it closes at the end of August. Again, thanks to state EMS-C managers and our many national partners for helping to achieve such a good response rate. Here are a couple of internal dashboards that NEDARC has used throughout the assessment process and that provide very useful information. The graph on the left is an image of the number of responses that have come in by each actual day of the assessment since we started in May. A couple of interesting things that we see. First, you can see that we had some high points on various days. 80 was our highest single day. 80 received assessments on June 9th, and we had 77 on June 30th. These spikes generally correspond to specific outreach effort. For example, June 9th was during the week that hospitals would have received the first postcard reminder about the assessment, and that entire week was really fantastic as far as receiving responses. The June 30th spike was probably a result of managers reaching out to non-respondents by phone or with the email template that we had provided. So we see a nice response there as well. It's also interesting, though, maybe not too surprising, to see that all the low points on the graph correspond to weekends. So even in a 24/7 environment, people generally don't take surveys on the weekend. The graph on the right is interesting as it shows the volume of responses summarized by day of the week, which is really useful information to know when administering surveys. It's kind of nice bell-shaped curve, and we see that the best day of the week looks to be Wednesday, with then Tuesday and Thursday being next best, and then Monday and Friday sort of rounding out the work week. And again, the weekend is when we see the fewest responses by a big margin. Let me talk for just a minute about comparability of scoring between assessment periods. If you look at this diagram, it shows a continuous cycle of development of guidelines and best practices for children in the ED, then assessing EDs based on those guidelines, identifying gaps from the assessment results, and then working on addressing the gaps. Over time, these guidelines must be updated to reflect new findings in research, emerging trends, and best practice. And so the cycle just basically continues. Because the guidelines changed from the last assessment period, the 2021 assessment was updated to reflect those changes, and that makes comparing results and scores between the periods very challenging. The scoring is still based on a 100-point scale, and the scores within domains has stayed the same. The total scores within domains have stayed the same. However, based on advice and input from clinicians, some individual questions have changed and some are new as a result of the updated guidelines. And the points within domains are to some degree distributed differently than in 2013. Some questions are the same between survey periods, and we are looking at ways to compare the same questions in both assessments and display those in our dashboards. One helpful way to think about that is that the overall score for each assessment is a reflection of general adherence to guidelines in existence and being used at a certain point in time, and recognizing that those guidelines necessarily have to change, at least to some degree, over time. So what are some of the lessons that we've learned this past year? COVID was a factor throughout all of this. We delayed the survey by a year and things were starting to improve with the pandemic, but then they started getting bad again in recent weeks. So we know the strain on emergency healthcare workers has been substantial during this process and has likely impacted our response rates. We also know that 2021 was a very busy year, and with back-to-back data collection projects between EMS and hospital. Again, we're trying to, we're grateful for all of the time that you've all put into this data collection effort this year, and we'll continue to try and minimize the lift of collecting data in future years. The role of the Pediatric Emergency Care Coordinator continues to be vital. We know that presence of a PEC is associated with increased readiness in the ED, and so we encourage EMS-C managers to continue efforts to promote this role to help increase the number of PECs in EDs. Finally, the crucial role of emergency healthcare workers just can't be overstated, as they have done so much for so many, especially during a very challenging time. So please, when you get a chance, thank an emergency healthcare worker. I'll now turn it over to Hilary for a few last thoughts.
Thanks, Mike. So let's talk a little bit about the next steps as the NPRP assessment comes to a close. First, the NEDARC team will go through and clean the data to ensure there are no major issues such as duplicate records. We will then begin analysis of the data, starting with general themes such as the overall state and national response rates and average NPRP scores. As we're cleaning and analyzing the data, Patty will be working on creating dashboards for results of general and specific elements of the assessment, and the NEDARC team will be creating summary reports for each state. As states start to receive the data, in addition to the PEC Workforce Development Collaborative, there will be many opportunities for QI projects on the state and national level. State managers can use their dashboards to target identified areas for QI initiatives within their region. The co-directors of the NPRP have already begun discussions and work on the main results manuscript and have outlined several other manuscript possibilities using the NPRP dataset. We hope to submit an initial manuscript as soon as we can get the data analyzed, hopefully by the end of the year. In addition, once the data set has been cleaned and analyzed, academic researchers can request access to the NPRP data by following the protocol described on the NEDARC website. As in the past, all research proposals will be reviewed by the NPRP leadership team and a statistician, and a data use agreement must be in place before data can be shared. We believe the NPRP assessment data is useful on many levels. Obviously, at its most basic, it is a quality improvement tool for each ED to track progress they are making towards improving pediatric readiness over time. And each domain can then be evaluated in detail for EDs to focus on specific projects, such as ensuring they have a pediatric emergency care coordinator or solidifying their disaster plans. On a state level, our program managers can look at trends within their state, identify areas where there may be gaps, such as geographic regions where EDs do not report behavioral health infrastructure for children, and try to target resources and efforts on a more regional level. Overall, we believe the assessment offers incredible value in giving us an actionable picture of the evolving state of pediatric readiness now and through time. Although the data from the assessment gives us mostly structural measures to analyze, several researchers have been able to link the weighted pediatric readiness score and other elements of the assessment to larger data sets, such as the National Trauma Data Bank and HCUP, to then move towards understanding how these structural elements affect outcomes in pediatric care. We have already several researchers ready to link the 2021 NPRP data to these patient-level data sets, and hope that this work will continue to help us understand how factors, for example, safety protocols or educational requirements for ED staff, affect pediatric morbidity and mortality for common conditions such as head trauma and sepsis. I'd like to share a quote we got during the assessment period. We are very interested in improving our pediatric readiness and also further participation in the National Pediatric Project. We've had many similar comments come through during this assessment period. And we're so appreciative that our end users, our ED nurse managers and medical directors, recognize the value in this project, as we do know that it is a time commitment for them to complete the assessment. However, we believe the GAP report, which allows immediate feedback and ability to focus on different QI measures, in addition to the work of research teams showing how elements of the assessment can be linked to outcomes, helps to motivate people to continue the work in this quality improvement initiative. Pediatric readiness does not begin or end with the assessment. It is a larger goal to create a culture of pediatric readiness that improves care and outcomes of all children. We'd like to thank you all for being a part of it. And now we'd like to open up the chat to try to address any questions anyone has. Thank you so much.
Hi, everyone. So I was on mute. I'm back. So that was a great session, and I always learn a lot, even though I'm part of this team. I want to make sure we address some of the questions that came in the chat, and then we'll also open it up for any other questions that people have as we've gone through this plenary. So we've addressed some of them, but one of the questions was whether this recording will become available. And yes, we will be adding all the sessions that you see today. to the landing page, given that there's no privacy concerns. And the second question that we had here was by Mark Albert. Can you all hear me? I'm seeing a message you can't hear me. Oh, you can. Okay.
Yes.
The next question that we had was by Mark Albert, and I'll just read it out loud. And if any of the NEDARC staff want to respond. With the questions about skills checking, do we have any information on what they are using to check skills? A validated checklist, a plus or minus minimum passing standard. And I believe, Patty, were you going to respond to this question?
I did. We don't have that, Mark. What the question is first it asks if you do a particular skill. For example, does your agency do demonstration skills to practice for pediatric specific equipment? And then after that, it asks the frequency. So the details that you're asking are actually not in the assessment. Hope that answers your question.
Thank you, Mark. And you can also, thank you, Patty, and thank you, Mark. And you can add some clarification, Mark, if you like on the chat. The other question we had was around a national and state by state report. We did mention that we're getting ready to send out that national report. And then we'll be preparing a template for the state by state report that you can create on your own. I believe Patricia Frost had additional clarification on whether on the report, and we do have our dashboards. Does Braden or Patty want to talk about that? That might be useful as well.
Yes, all states have their Tableau dashboards, which does have their state summary for all the EMS data, which has been completed and cleaned. So they do have their final results that they can share with stakeholders. So those are available now. So they can go ahead and print off pages or do some filtering and share that with whoever they'd like.
And those are all the questions that we had not addressed explicitly. There was an earlier question around building clinical performance measures that could be used side by side with the EMS Compass or the NEMSCA listings. We mentioned that NEMSIS might have some more information on this, but I'm not sure if anyone else wants to add a response to that question. Okay, are there any additional questions? So I see on the chat, Laura responding to Mark. We have a lot in the chat, so give me a moment here. So Laura responding to Mark's question says he brings up a really good point. The question right now asks about modality and frequency of evaluation of pediatric specific skills, which is, the simulated event, a field encounter, or a skill station. And Erica Kane has a question for the group. When will NPRP open for the QI period following the current assessment? I hope that some of the EDs that didn't participate during the official survey period will come back later and do it at a later date.
Hey, can you hear me? Eddie, can you hear me?
Yes.
All right, thanks for the question. Erica, well, the short answer is we don't know. It's going to be a while because there's a lot that goes into that because we have to get into a new version of our survey software and reprogram the gap report. So it's going to be a while, but we'll, as far as having the QI portal open in the same fashion that it was last time. But we're working on solutions to that and seeing if we can, what the timetable will be for that, and we'll let folks know as we know more.
And when Mike says reprogramming the gap report, it's different during the QI because you'll be able to see your score that was during this year compared to when you take it again. So, it will look different.
Thank you. And we're going a little back and forth between NPRP and EMS for children. So Patricia Frost is asking clarification around the dashboards if they are public. They're usually, my understanding is that I'll let Patty and Braden respond, I believe, on the dashboards.
The dashboards there are certain dashboards that are public. The dashboards that we talked about earlier for states and state summary data are accessible by the EMS-C managers for that state and or PIs. So they are the only ones who can actually download those, but they are free to share them with who they feel is appropriate.
Thank you, Patty. We have another question from NPRP here. Would a state be able to use that QI tool statewide, or is it meant for individual hospitals?
I know Mike's not on, but we did have, last time there was the QI period, it went from 2015 to 2019. We did have some states who completely resurveyed during that time, like 100% of their hospitals, and they did do a comparison on their own for QI. It's mainly meant for hospitals to gauge their QI efforts and what they've implemented in order to get more peds ready. So that's really the goal, and the purpose of it is on an individual hospital level, but some states have chosen to use it differently.
That's right. That's right. Patty mentioned it's when we open the QI portal, it's really, there's not a push nationally for hospitals to go in and retake it. It's just, it's available for hospitals to do. And so it will largely be hospitals that are interested and want to, maybe have made some changes and want to see what their score is currently. So, I mean, the state can try to encourage hospitals in their state to take the assessment, but it really is sort of a hospital, focused effort at that point. And the QI portal, when it does open, it will be open for some time and available, and we'll close it basically before we do another national assessment. So there's some downtime, but again, that period hasn't been decided either. So we'll just have to provide more information as we know more.
Thank you, Mike and Patty. We do have a question from Joe Stack that I missed here. It's regarding the EMS for Children survey. Is the chart that showed the response rate by total number of agencies per state available on the dashboard?
No, that was actually made for this slideshow. I can talk to Mike and see if we can send a copy out to all of you.
We have 2 minutes, but we also have one question from Patricia. Is there any collaboration with the NREMT on these skill issues?
I'll have to pass some of this to Mike. On this survey, we can't change the question. Maybe T can jump in. They were approved. They went through OMB approval. So there's a lot to these questions that they went through. But as far as that particular question, I'll let Mike and T answer that.
Yeah, it's that these performance measure questions were developed, some time ago, actually over quite a long period, with a lot of input from EMS stakeholder groups and representation from NREMT and NAEMT. And the questions will stay as they are for gathering EMS performance measure data. However, again, we're in the process of developing a more robust assessment tool for what we call the pre-hospital pediatric readiness project, which is sort of like a mirror to the NPRP in the pre-hospital setting. So, and that assessment will have more questions and more information that will be gathered. I don't know exactly, because I haven't been working on that project as closely, but there'll be, I think, more opportunities for to get more, more layered and deeper information in some of these areas with the PPRP assessment.
Thank you. And we have one final question from Renee Escamilla. Will the EMS-C program managers be able to see the individual gap reports securely, of course?
Yes, that is our plan. As far as when, we are still working on that, but absolutely that is our plan, is that you will be able to view individual hospital level data. But of course, you will be bound by some confidentiality regulations.
Thank you. Well, we are past our time, or we are at time. I wanted to thank you all for your very active participation in this plenary session. If you have any questions for any of us, you can reach us directly via our email, or just catch us during the grantee meeting. For the next session, please stay tuned for a wrap up with our EMS-C branch chief, T. Morrison Kanata. Thank you all.